From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. Glioblastoma is the most common malignant brain tumor and one of the most aggressive of all solid tumors. Several newer and investigational therapies offer new strategies for treating glioblastoma. These include portable devices that generate tumor-treating electric fields and investigational immunotherapeutics. Here to tell us about the latest developments in glioblastoma treatment is Dr. Eric Wong. He is an international expert on advanced treatments for glioblastoma and a professor of medicine, radiation oncology, neurosurgery, and neurology at Brown University. Dr. Wong was interviewed by Dr. Christoph Stretz, Vascular and Critical Care neurologist at Brown. Here's Christoph.
Well, welcome, Dr. Wong. Thanks so much for joining us today on ANA Investigates.
I'm very happy to be here.
Let's just start off by giving our listeners a bit of background. In 2021, the WHO reclassified what used to be known as glioblastoma, or GBM, into two separate diagnoses based on the isocitrate dehydrogenase, IDH, mutation status. Could you remind our listeners what those two diagnoses are?
The WHO has integrated both histology and molecular diagnostic into one integrated platform. In other words, neuropathologists have to look at the histology and then get additional molecular studies in order to define the exact diagnosis of the glioblastoma. And this resulted into two major types of glioblastoma. In the past couple decades, we always know that there are glioblastoma in the older population and glioblastoma in the younger population, and they are different. In the older population, they are called the primary glioblastoma, in which they develop de novo, whereas in younger patients, the glioblastoma evolve from a lower grade astrocytoma. So the integrated diagnosis, WHO 2021, basically used molecular genetics to define the two major types. The one that occurs in older patients are called the IDH wild type, and the name glioblastoma remains. However, in the younger patient, it is called astrocytoma grade 4 IDH mutant, okay? The word glioblastoma is not there. It doesn't mean that it is not aggressive. It just means that the evolution of these two glioblastomas are different.
Great. This was a wonderful overview. And I think for our discussion today, I would like to focus on really the glioblastoma and glioblastoma therapy. Would you be able to review for us what the cornerstones of standard therapy for glioblastoma are?
Yes, most patients begins with a maximum safe neurosurgical resection. Usually what that means is that we ask our neurosurgery colleagues to take a look at the scan and to see whether or not all the enhancing portion of the tumor that is shown on the MRI scan can be removed. If that cannot be removed, then we just need to do a biopsy, make the diagnosis, and then the patient goes to the next set of treatments. However, in the past 5 to 10 years, there has been this movement into what neurosurgeons call supramaximal resection. So not just removing the entire enhancing tumor on the MRI scan, but removing the surrounding brain up to the physiological boundary. For example, a glioblastoma tumor in the left frontal brain, a neurosurgeon can do awake craniotomy and do language mapping intraoperatively to remove as much of the glioblastoma without hurting the patient's language function. So that is called supramaximal resection. And there's a movement towards that. Patients who underwent supramaximal resection, they live longer. And the reason is because this is an infiltrated tumor and there are tumor cells in the surrounding brain. After maximum safe resection, the next phase of treatment is radiation and daily chemotherapy called temozolomide. And the radiation can occur over 6 weeks or 3 weeks, depending on the age of the patient. And after everything is done, patients would get at least 6 cycles of adjuvant temozolomide at double the dose, but just for 5 days, recurring on a monthly basis for 6 months or even 12 months. So that's the general scheme of the conventional treatment for glioblastoma.
Thank you so much for that initial overview of cornerstones of therapy. There have been some advances in treating patients with GBM more recently. And one of the questions I'd like to ask is about the role of tumor treating fields, what they are, and how they work.
Well, thank you for asking this question because tumor treating fields is kind of like a mystery to a lot of the neuro-oncologists. But I would like to start that by saying that tumor treating fields is a physical modality of treatment. And the closest one that is similar to tumor treating fields is ionizing radiation that everyone is familiar with. When we are dealing with a physical modality of treatment, there are a whole host of biological effects. So, for example, in radiation, we know that radiation causes double-stranded DNA breaks, and patients with certain genetic disorders like BRCA1 and BRCA2, they have a fulminant radiation response. Radiation can also cause single-stranded DNA breaks. In our patient population, in the glioblastoma, if they have this DNA repair enzyme called 6-methylguanine methyltransferase or MGMT that is silenced or methylated, the promoter is methylated, then they would have a bigger response. And these are the patients who have a fulminant response, and after radiation, they may have a lot of swelling in the brain. Now, radiation can also cause something that's called an abscopal effect. And abscopal effect means that when we irradiate a tumor in one part of the body, tumors at other parts of the body can also shrink. And this is via an immunological mechanism because radiation releases the tumor antigen. If the patient's immune system is healthy and robust, it will mount an anti-tumor immune response. And it is the immune cells that cause other tumors to shrink at other parts of the body. So as you can see, radiation can have a whole host of effects, and so is tumor treating fields. And the tumor treating fields, in my opinion, it can have a direct effect on the tumor cells, and it can also have an indirect effect on tumor cells. The direct effects that we most commonly know about is the interference with mitosis. And this is not interfering with chromosome segregation. This is interfering with the splitting of the cytoplasm because there are some high molecular weight proteins that are dipoles that are knocked out of its usual position when a cell is dividing. And as a result of that, the cell cannot divide completely. The cell is stressed. And then all these immune mediators go to the surface of the cells for immune recognition and immunogenic cell death. So tumor treating fields was shown to be efficacious in newly diagnosed glioblastoma population. There was a big trial that was performed at the end of the 2000s, and it was published in 2015 and 2017. And it shows a prolongation of progression-free survival as well as overall survival in newly diagnosed glioblastoma population. Now, one of the criticism is that this trial was not double-blinded because there was no sham treatment of those patients who are wearing the device on their head. But it cannot be completely blinded, primarily because the arrays on the patient's head, when the patient turns on the generator, it will generate heat. It will give it away. But this is the best that we can do. But it has been an accepted modality of treatment for glioblastoma since 2011 for recurrent glioblastoma and since 2015 for newly diagnosed glioblastoma.
Thank you so much for that description. And I'd like to ask, just from a practical application standpoint, you mentioned the patient wears the device. How long do they have to wear it? Is it something they wear almost the entire day? And is it something they have to do during the time of treatment?
Yeah, this is a very good question because the alternating electric field has to be there, and it primarily affects the tumor cells as they divide in mitosis. The field has to constantly be there, ready for the tumor cells that is dividing. So the best data that we have is that patients have to wear it for 75% of the time. That's approximately 18 hours per day. Now, obviously, one cannot wear those arrays on their scalp indefinitely because the hair may grow out. So every 2 to 3 days, patients would need to take the array off, wash their scalp, and shave their head. So yes, we would like to have the patients to wear it as long as possible, preferably at 75% or 18 hours per day.
Thank you so much for that response and how you have used tumor treating fields. I'd like to ask you about investigational therapies for glioblastoma, specifically some categories of immunotherapy that are being studied at the moment.
One of the more exciting experimental treatments that we have are immunologically based. Now, unfortunately, immune checkpoint inhibitor has not been shown to be efficacious in controlling glioblastoma. There were 3 randomized studies that uses immune checkpoint inhibitors for recurrent glioblastoma, for IDH wild type newly diagnosed glioblastoma, and IDH1 mutant newly diagnosed glioblastoma. And all 3 trials did not show adding immune checkpoint inhibitor is better than conventional therapy. However, it doesn't mean that immunotherapy does not have a role. We have a variety of immune strategies that we are investigating. So, for example, we have immunotherapy that are single agent based. In other words, find a tumor antigen that is commonly expressed by glioblastoma, and then you mount an immune response against it. So a good example of that, it would be anti-survivin cancer vaccine, and that is against one antigen. About 5 years ago, we had a randomized phase 3 trial of this immunotherapy CDX-110 that is directed at epidermal growth factor receptor V3, which is a truncated form of epidermal growth factor receptor that is only expressed in glioblastoma. Unfortunately, that trial did not show better efficacy compared to conventional treatment. There are also trials that incorporates 6 antigens. So there was a trial with this mixture of antigens called ICT-107, and it has 6 more common antigens that are expressed by glioblastoma population. Unfortunately, the trial did not go into fruition because of some problem with funding. But more recently, there are these vaccines that utilizes the patient's immune system to generate a vaccine. So because glioblastoma is a heterogeneous disease, what happens with these vaccine programs is that the tumor comes out, the tumor would be treated, and then the tumor antigens would be presented to the patient's immune cells. So for example, in DCVax, the dendritic cells is isolated, the tumor is also isolated, the tumor is treated, the dendritic cell sees the tumor antigen in a petri dish in order to be sensitized, and then the dendritic cells is re-injected into the patient. That trial is being analyzed right now. There's also another trial that we are performing here at Brown. It's called the IMVAX trial, in which the tumor also comes out from the patient. It goes to the sponsor. The sponsors treats it with radiation and also IgH1 oligonucleotides, and then it comes back to the patient. But the interesting thing is that the treated tumor is implanted back into the patient in this biodiffusion chamber to allow the patient's own immune cells to recognize the tumor antigen and then eventually be sensitized to the tumor antigen for immune destruction of the glioblastoma in the patient's head.
Wonderful. Thank you. we always kind of like to ask for junior faculty who are interested in this area, what do you think that most of the areas going forward, if we look at the next 5 years, 10 years, lie in terms of glioblastoma research and treatment?
One of the important things that we realize is that glioblastoma tumor is unlike melanoma, unlike non-small cell lung cancer. There aren't that many mutations in the genome. There aren't that many somatic mutations in the tumor cells. So in the 2021 WHO criteria, there's a new definition of midline glioma in children, in young adults, that are just as devastating as glioblastoma, but we don't call them glioblastoma. We call them H3K27 mutated glioma. We call them H3.3G34 wild type glioma. Now, these tumors, they are mutated because of epigenetic changes. And there are epigenetic drugs that are coming out. And I think the junior neuro-oncologists, junior neurologists will see these drugs when they finish training and going into practice. So this is what I tell our residents, our fellows in training. I may not be seeing the full spectrum of epigenetic treatment for glioblastoma, but the junior people will. And that is very exciting because there's another class of drugs that can be at our disposal.
Thank you, Dr. Wong, for a great conversation today about advanced therapies in glioblastoma. I think we all learned a lot, and it was wonderful to have you here today.
Well, thank you for having me here today.
That was Dr. Eric Wong, Professor of Medicine, Radiation Oncology, Neurosurgery, and Neurology at Brown University, interviewed by Dr. Christoph Stretz, Assistant Professor of Neurology at Brown. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Michelle Johansson. I'm Adeline Goss, podcast host and executive producer. Our program was produced today by Christoph Stretz, Caitlin White, and me, with help from Jen Hurley. You can listen to past episodes of the show, subscribe to us so you never miss an episode, and access all of the ANA's educational programs on the Education tab at myana.org. That's it for ANA Investigates. See you next month.